We have thousands of studies mapping what happens in the first 24 months after bariatric surgery. The initial weight drops and improvements in blood pressure are meticulously tracked. But look out to the 10-year mark, and the data goes dark. This is especially true for laparoscopy sleeve gastrectomy, or LSG. LSG is a primary bariatric procedure that removes approximately 80% of the stomach, leaving a narrow tube that physically restricts food intake and alters appetite-regulating hormones. When patients cross the 5-year threshold, clinicians are often flying blind. Without robust, decade-long evidence, it becomes difficult to distinguish between normal physiological adaptation and surgical failure. To accurately predict how a patient's body and behavior will adapt a decade later, we have to strip away the noise. We need to isolate the variables. Without clear, long-term visibility, postoperative care remains entirely reactive. Doctors end up treating weight regain after it happens, rather than anticipating the biological shifts that cause it. A recent study provides that exact visibility. Researchers tracked a prospective cohort of 193 patients for 10 full years following their primary LSG procedure. The researchers applied a strict filter. They absolutely excluded any patient who experienced major surgical complications, like staple line leaks or strictures. By removing those complicated cases, the data isolates the pure, unhindered effects of the surgery itself. We get a clear look at how the altered anatomy interacts with time and behavior. The findings challenge a core assumption in bariatric medicine. The data shows that a predictable physiological regain in weight does not equal a collapse in the patient's long-term quality of life. Clinicians often assume that rising numbers on the scale indicate the procedure has failed. The statistical reality points to a different culprit entirely: behavioral stagnation. The decade-long timeline proves that patient management must eventually pivot away from strictly monitoring weight and focus directly on targeted behavioral interventions. To understand that pivot, we need to trace the anthropometric data, the physical measurements of the human body, starting at baseline. Before surgery, the cohort's mean body mass index, or BMI, was 42.5. The immediate post-operative period is characterized by a rapid, intense physiological response. This chart tracks the cohort's BMI changes over a 10-year period after surgery. We see a steep drop in the first 12 months, plummeting from that 42.5 baseline down to a mean BMI of 29.0. The curve then begins a stabilization phase. The weight loss levels out as the patients enter their 3rd year, hovering in a trough near the 30.0 BMI mark. This initial plunge is driven by maximum anatomical restriction and a sharp reduction in appetite-stimulating peptides like ghrelin. The stomach's drastically reduced volume forces a severe caloric deficit. By the 3rd year, the body adjusts. This marks the critical clinical inflection point, where the patient's physical trajectory changes direction. Those first 36 months represent a temporary window. It is the period of maximum mechanical restriction and intense metabolic advantage. Once that window closes, a new clinical reality sets in. The body begins to reclaim mass. Looking at the exact same chart from the 3rd year onward, there is a continuous upward slope, eventually settling at a mean BMI of 32.0 by year 10. The delta annotations reveal steady, incremental additions, typically averaging 0.3 of a BMI point per year. By the end of the decade, that steady accumulation results in a 9.4% increase in mean BMI from the year 3 trough. It is tempting to look at that 9.4% increase and label the intervention a failure. Medical professionals frequently interpret any upward trend on the scale as a sign that the patient has relapsed. But a broader look at the cohort contradicts that assumption. A decade out, 51.5% of these patients successfully maintained greater than 25% excess weight loss. This 9.4% increase reflects a mild physiological adaptation phase as the body finds its long-term equilibrium. If we assume that a rising BMI directly harms a patient's subjective well-being, the data should show a corresponding drop in satisfaction. The psychometric results tell a different story. This bar graph illustrates long-term quality of life improvements after LSG. A massive 55.15% of the cohort reported an excellent improvement in their quality of life at the 10-year mark. Combining the top 2 tiers shows that over 72% of patients report highly positive outcomes,
completely decoupled from their recent mild weight regain. To understand why they feel so good despite the scale moving up, researchers utilized the Moorhead-Ardelt Quality of Life Questionnaire, or MA2. The MA2 is a validated scoring system that breaks global satisfaction into 6 distinct functional domains. This chart displays the mean scores across the 6 MA2 domains. The highest scores are concentrated in the psychological and interpersonal categories, specifically self-esteem and social functioning. These specific psychological benefits are robust and highly durable. The confidence gained from the initial massive weight reduction persists long after the body begins to reclaim a few pounds, but the scores drop significantly when it comes to the practical, daily execution of healthy habits. The lowest performing domains are physical activity and eating behavior. This creates a clear clinical paradox. The surgery succeeds in permanently elevating a patient's self-esteem and social participation, but it struggles to resolve the execution of daily healthy behaviors. The lag in physical activity points directly to a behavioral bottleneck. To put this in context, we have to look back at the baseline. Before undergoing the procedure, 74.2% of the cohort was entirely sedentary. Immediately after surgery, patients typically experience a surge in mobility. The rapid weight reduction makes movement easier, prompting a widespread behavioral shift toward exercise. 10 years later, the data tests the durability of that initial motivation. These pie charts break down the intensity and frequency of physical activity patterns 10 years after surgery. The blue sections reveal a heavy reversion to old habits. A full decade after undergoing major metabolic surgery, 40.8% of patients report zero physical activity intensity. They have reverted entirely to a sedentary lifestyle. On the other end of the spectrum, only 38.1% of the cohort consistently engages in physical activity of an intensity high enough to sustain optimal metabolic health. Removing 80% of the stomach guarantees caloric restriction, but it cannot override human habits. The surgery physically alters the gut, but it does not cure the underlying pathology of sedentary behavior. This 10-year data forces a reevaluation of how we define long-term bariatric success. This pie chart shows the long-term expectation outcomes reported by the patients themselves. Despite the physiological regain and the sedentary habits, 73.2% of the patients rate their surgical outcome as outstanding. The patients are satisfied, but the medical reality is stark. That 40% sedentary rate carries severe risks for long-term cardiovascular and metabolic health. Because a mild physiological regain is practically guaranteed by the 3rd year, medical protocols have to evolve. Tracking a patient's weight is no longer enough. The mandate for practitioners is clear. They must anticipate the year 3 physiological plateau and proactively deploy targeted psychological and behavioral interventions before the patient's habits fully regress. Treating LSG as a standalone, purely surgical cure leaves the patient vulnerable. It effectively sets them up for long-term behavioral stagnation. We need a continuous care model, recognizing the limits of anatomical restriction. As metabolic advantage wanes in the 3rd year, formal intervention must step in to replace it. This precise timing bridges the gap between acute surgical effects and the demands of lifelong habit formation. This requires a highly multidisciplinary approach. It means integrating ongoing nutritional counseling, dedicated physical therapy, and persistent psychiatric support directly into the postoperative roadmap. The initial surgery provides the necessary physiological foundation, but it is the ongoing behavioral support that truly locks the entire structure securely into place. True 10-year success is achieved only when the surgical alteration of the gut is matched by a permanent clinical commitment to behavioral adaptation.